All right, we are recording. All right, so we're doing the cardiovascular system today, only the heart. So we're going to do blood vessels later on. Before we even start, because we are dealing with blood flow, we want to make sure that we understand arteries take blood to the heart or away from the heart? All right, and therefore veins take blood. All right. Under 99% of conditions, arteries are also carrying what type of blood? All right, and veins are deoxygenated. Where is one of the few places where that's not true? Pulmonary circulation. Good. All right. So one of the reasons why I want to get that off my plate right away is that we're going to start by talking about fetal blood circulation. And when we talk about fetal blood circulation, we have to talk about how blood is getting to the actual fetus. So these umbilical vessels, artery and vein, arteries and vein, sorry, transport blood back and forth from the fetus. And you notice that blood enters fetal circulation via the umbilical vein. All right? So blood's going to the fetus from the vein. But I thought that veins carry blood away from the heart.
Away from the maternal heart.
Away from the maternal heart toward the fetal heart. Right? So the umbilical vein is going to carry blood into the fetus. Okay? I also have a clicker that I don't have a battery for that will allow me to be over here and stuff good. So this slide's forward. I'll get that underway sometime. So it's kind of weird. We're talking about fetal circulation before we talk about real circulation. But you're going to notice some of these things have already come up in anatomy. So it shouldn't be too much of a stretch. So when that blood comes in, we're going here in the umbilical vein. We're going to partially bypass the liver, all right? Everything in the fetus is living tissue, but not everything in the fetus is going to be processing nutrients like an adult would. So we need to keep the organs alive, but we need the blood to be circulating all over the place. So we partially bypass the liver, just enough to keep it alive, but want it to go into the main circulation. So then it's going to go here and bypass the liver, go into the inferior vena cava. Excuse me. I'm trying to talk and walk, and I just got here and I'm stressed. And so then we come in. We're going to go to the vena cava. We're going to go into the right side of the heart, right? Normal circulation, you guys have gone through this. And normally we would go into the right ventricle and then to the pulmonary circuit. And it still does that, but we also have a hole between our atria, and that's called the foraminal valley. And that foraminal valley allows blood to be shunted from the right side of the heart directly to the left side of the heart. All right? Why are we doing this? Why are we doing this? Right, their lungs are filled with fluid. They don't need really intense circulation. You need to keep them alive, but they're not working like they should. So remember, we're in a fluid-filled sac here. All right, so then blood is going to come. So we partially bypass the lungs. Blood in the left atrium then is going to go to the left ventricle, out through the aorta, and then out to the body. But that blood from the right ventricle, as it's going into the pulmonary trunk, does go to the lungs, but then it also bypasses lung circulation by going through something, I suppose we should go to the next slide, called the ductus arteriosus. So that is literally a duct between the pulmonary trunk and the aorta. All right, we'll talk about what happens to that once the baby's born, but bypass the lungs that way. And so everything from the left ventricle and everything, or about most of the blood from the right ventricle, is going to end up in the aorta and then back out to the rest of the body to give organs their blood supply. Okay, so three places where you bypass: liver, atria, and pulmonary trunk. All right, we have a shunt towards systemic circulation. All right, after that, you're going to go to the rest of the body. Blood is going to leave fetal circulation through the umbilical arteries, which are branches off of the internal iliac arteries. All right, so again, arteries away from the heart, away from the fetal heart. Now you're going back toward maternal circulation. All right, 2 umbilical arteries, 1 umbilical vein. If you ever get a chance to go in a NICU and see these newborn babies, sometimes they have catheters in their umbilical arteries. Really sad, but neatest thing I've ever seen in my life. It's super cool. And I thought I was going to hate OB/GYN. Actually, I hated the OB part. Actually, no, I hated the GYN part. I like the OB part. Okay, so what this is showing you right here is basically circulation in the fetus. I'm not going to go through all that. We just went through it. I want you to be familiar with the 3 places where blood gets bypassed in the fetal circulation. And then here is comparing fetal circulation to adult circulation, showing you what happens in green. So what I want you to pay attention to is what's in green for future reference. What happens to adult circulation. So the next few slides will talk about that. So this would be a good summary slide to come back to. All right, once the baby's born, all right, you can't have fetal circulation anymore. Now you have to start using your liver because you're eating food. Now you have to start using your lungs because you're breathing air, all right? And you're not dependent on mom's blood anymore. So what happens is that the umbilical vessels, artery and vein, constrict, all right? And it's like pretty quick. It's within hours. Okay, if they're going to catheterize the umbilical arteries in the fetus, or I'm sorry, the umbilical vein in the fetus, they need to do it quickly because they shrivel up and you can't access them almost right away. Okay. The umbilical arteries become superior vesical arteries. That means they are attached to the urinary bladder. So if you look in the cadaver, you can find them as the superior vesical arteries. And the umbilical vein becomes something called the ligamentum teres, all right, which is attached to your belly button. All right, that ductus venosus, that's the liver part, that will constrict, all right, and as it constricts, functionally 1 to 3 hours, so within 1 to 3 hours, it's going to constrict and no blood is going to go through there anymore. So that's what we mean by functionally. Structurally, it takes about 2 days to almost 3 weeks to functionally close. And that means physically, there's no hole there anymore. All right, that foramen ovale that you guys were finding in your hearts yesterday, that's neat. So between the atria, right here, right, left, we have this flap, right? And in the fetal circulation, blood's going right through that flap. In neonate circulation, the pressure in the left side becomes much greater and forces that flap shut. Okay? So the pressure here is just going to force the flap shut. It hasn't closed. It hasn't sutured itself to the wall yet. It's just mechanically closed shut because of the pressure difference. All right? And it's going to stay that way until connective tissue forms and kind of seals it shut. So if something comes, imagine something coming along and stitching it up, right? And then it's fully closed. All right, and that's what we mean by becoming adherent. So the process of it becoming adherent takes about 6 months to a year. So that takes a much longer time to happen. And the reason for that is since it's a flap, you know, even though pressure differences are going to keep it closed, it's still going to be a little bit flapping, right? So it's going to take a while to, you know, batten down those sails. All right, then the ductus arteriosus up here will constrict and become the ligamentum arteriosum, which is one of those structures you had to find between the pulmonary trunk and the aorta. All right, like the ductus venosus, that will functionally close within hours. All right, so nothing will go through there, but structurally in about a week, it'll close off.
Do we need to specifically know the functional and structural closing times?
Nope. Nope. I add those because I get a lot of questions of, well, when does this occur?
Gotcha.
I always forget, so I put them in my PowerPoint. So the more questions you guys ask, the more actually gets added to my PowerPoint for the next year.
Also, if we throw in the word gag in there, everyone said that ligamentum arteriosum sounds like a Harry Potter spell.
Ligamentum arteriosum. Yeah, I heard somebody saying that yesterday. Well, it's Latin, right? And all these magical spells are based on Latin, too. Expelliarmus. All right. Sometimes these circulatory pathways don't close properly, and we end up with some congenital defects. One of them is a patent ductus arteriosus. Or patent, if you want to be strict about it. If that happens, all right, in neonatal circulation, in our circulation, what has higher pressure? Pulmonary circuit or systemic circuit? Systemic circuit. Remember, left ventricle, really muscular, right? Pumping blood out to the whole body. It's going to have a much higher pressure than the pulmonary circuit, especially since the pulmonary circuit's like, you know, right here is like, you know, kind of have to pump. All right, so because of that high pressure, if you have a patent ductus arteriosus, blood's going to flow from the aorta into the pulmonary trunk. All right, so we call that a left to right shunt. Going from what's being pumped from the left side of the body into the right side. I'm sorry, left side of the circulation into the right side of the circulation. Does that make sense? So that's a left to right shunt. And that's why, because of pressure differences. All right. So what that's going to do is not get as much blood out to the body, which we call diminished cardiac reserve. All right, you're not pumping blood out to the rest of the body. And then you're overloading the lungs at that point. So they're going to have a lesser reserve as well. All right, usually you hear this as a murmur. All right, this is physiology, not pathophysiology, so I'm not focusing too much on this stuff. But I want you to be aware of a couple conditions, and you'll probably cover it in Clin Med. Another one you may have heard of is the Tetralogy of Fallow. Tetra means four, right? So 4 things going on here. All of which contribute to a right to left shunt. All right, even though pressure differences favor the left side, this one is going to move from right to left. Why? One, you have an overriding aorta that opens into the right ventricle. Where's the aorta supposed to open into? Left ventricle, right? So if you're opening into the right ventricle, then both ventricles are pumping through the aorta. All right? In that way, we're going from right to left circulation. Does that make sense? Pulmonary arteries are going to be stenosed. All right, so our pulmonary arteries, what does it mean? What does stenosis mean? Pardon? Constricted, right. Or hardened. So it's going to be harder to get blood to your lungs. So what's blood going to do? Back up, right? Where's it going to go? Aorta. Ventricular septal opening. So you have this opening between the left and right ventricles, again, mixing of blood, and an enlarged right ventricle. So an enlarged right ventricle, because it's got to pump up gets these narrowed pulmonary arteries, it's going to have to get thicker, it's going to have to get bigger to compensate for that, which is going to make the problem even worse, right? So all of those are going to do a right to left shunt, not as much blood getting to the lungs, therefore not as much oxygen getting to the tissues. These people are pretty sick. All right. You guys care if I throw that away? All right. Cardiac pain. She's like working late. She's done with the lecture today. See, you guys don't. I should walk back there and see what you referred cardiac pain. You guys have heard of this before. When you have a heart attack, where are we feeling it? Arm. Well, okay, it depends on who you are. If you're a female, you're telling me it's elsewhere than if you're a male, right? You guys know that. Females detect cardiac pain differently than males do. That's really, really important to understand. We're not going to talk about that here, though. Why do we feel pain when our heart's hurting? Pathologically, not because we're sad. Elsewhere, well, both our heart and our upper limbs originate in the same embryonic area. So the pain receptors are going to originate from the same area too. So when the heart starts feeling pain or starts signaling pain, it's going to send it into the same spinal area where the arm would signal pain. And therefore we get this referred pain effect. All right, because our brain's going to interpret it the same way, whether it's coming from the heart or whether it's coming from the arm. So that's why we feel it in our arm as well. Do we really feel pain in our arm or in our heart? No, we feel it up here, right? This is where it's interpreted. All right, so there were some questions yesterday when we started going over the heart in the lab. One of which was, where's the base of the heart and where's the apex of the heart? All right, usually you think of the apex as being the top of something. You climb Mount Everest and you're like super happy. Right? But an apex means a point. All right, and it just so happens the point of the heart is pointing down. So the apex of the heart is at the bottom. The base, which is this area, there's no specific, like, yeah, that's the base. It's this area, is at the top. All right? And notice that the apex is pointing to the left. Right? Correct? Yes. What else do I want to say about this? All right. So, the way the heart's laid, this is incorrect. You know this, because which set of chambers is facing anteriorly? The right side, the right ventricle, right atrium. So if I were to stab you right there, you'd be compromising pulmonary circulation first. Okay, I'm not going to stab anybody. All right, other things to notice from this, right side of the heart, pulmonary circulation, left side of the heart, systemic circulation. All right, so two other terms that I want to show you. I don't know if you typically talk about it this way, but I do, and people are like, what are you talking about? Systemic and pulmonary circulation. Left, right. All right. I don't know. So when I leave Mercy College and somebody else takes over anatomy and somebody different takes over physiology, are these things going to be taught differently? Because technically you should be, this is anatomy stuff, right? The heart wall. I'm talking about in physiology though. because we don't even cover it in anatomy, I don't think. Was it in the lecture? Heart wall stuff? Okay. All right.
Just to be clear, you're not leaving, are you?
No comment.
At some point.
Will it be within or after 2 years?
At some point, I'm out of here. My long-term goal is a mental health provider, so not a PA instructor. Yes, I'm finishing my nursing degree. This is all recorded. Finishing my BSN and going towards an NP in psychiatric. So, if you guys didn't pick up on my one of my announcements, I said I'm at clinicals on Saturday. I work at a rehab hospital. Opiates, alcohol, benzos, things like that. So, if you have any, no, we are not taking anybody shadowing. They're just not doing it. I've already had people ask. So, if you have questions or want to know any more about it, I'm happy to talk about it. All right, back to the heart, which is the seat of our emotions, right? All right, heart wall. Since we have talked about this, 3 layers. You have your, I'm going to start from the bottom here, your endocardium, which is the part of the heart that's in contact with blood, smooth, shiny surface. The purpose of that smooth, shiny surface that is actually continuous with the endothelial cells is to provide a relatively frictionless surface for blood to cross. If you have a friction surface and blood flow is really turbulent, what happens? Clotting, right? Then you have the main business end of the heart, which is your myocardium. That's that muscular layer that's involved in pumping, all right? And what most of our lecture is going to be focused on. And the epicardium on the outside, and that's that thin layer on the outside that covers the heart. It's the same structure as the visceral pericardium. So the epicardium is the visceral pericardium. All right, then of course on the outside of that you'd have the parietal pericardium. And we discovered yesterday in your bare bones it says that your pleura have pain receptors. Do you remember which ones? No. Wasn't it parietal? You were asking this question. Same thing in the heart. It's a parietal peritoneum that has the pain receptors here. That's nowhere in your anatomy though. All right, so I'll go through this really quickly because you guys, I feel, probably have a good feel for this. You have 4 chambers, atria and ventricles, left and right. Atrium, left and right ventricles. Where did the atria pump to? The ventricles. And where do the ventricles pump to? Pulmonary trunk and the aorta. All right. Other thing to notice, if you hadn't got this by now, left ventricle versus right ventricle, when you're looking at the heart, you can tell the difference because the outside wall of the left ventricle is way thicker than the outside wall of the right ventricle. And the reason is this is pumping up to the body, it gets the high resistance. Pumping just to the lungs, it gets the low resistance. All right? 2 sets of valves. You have your AV valves or atrioventricular valves. I'll usually refer, since I'm usually talking about the whole heart, I'll refer to the AV valves or the semilunar valves. I won't refer to them as bicuspid or tricuspid. So be familiar with that terminology. Tricuspid on the right side, bicuspid on the left. I teach my undergrads, try right, buy left. Like you're going shopping, try the right, but buy the left. All right, and these are attached to these cord structures called chordae tendineae, which are in turn attached to these muscles down here called papillary muscles. All right, so when the ventricles contract, the papillary muscles also contract, pull on these cords and snap those cords shut, snap those valves shut. All right, then we have our semilunar valves. between the left atrium and the aorta, called the aortic semilunar, between the right atrium and the pulmonary trunk, pulmonary semilunar. You can't mess up the names of those. We haven't gone over it yet, but so if coronary tendon and capillary muscles close the AB valves, what closes the semilunar valves if there are no cords attached to it? That flow of blood, right? So the blood is pumped through. You contract the ventricle. I was going to say aorta. You contract the ventricle, pushes blood out, right? Pressure's high. Ventricle starts to relax. Blood flows backwards, fills these cuffs, snaps them shut. Okay, so that's what closes those valves. I haven't found a good video that shows that. Who was I talking to? Was it you? Yeah, I haven't found. I looked this morning. I was like, all right, I gotta find a good video. And I told you there's probably good videos out there. There's not good videos out there. All right. And then we have coronary vessels. I'm not going to cover coronary vessels in here at all. Just put them in here to remind you guys that you do have to know certain coronary vessels. That's an anatomy thing. We're not covering them at all in here. But what I do want to say about them is that in your aortic valve, left and right cuffs, there are openings to the coronary vessels. So when blood pumps out into the aorta, these valves are pushed. So these openings are closed, right? When the left ventricle is pumping, these valves are closed because these holes are closed because the valves are pushed up against them. But when the ventricle relaxes and these valves snap shut, that's when filling of coronary arteries occurs. Okay, so that's kind of paradoxical, right? Because you think of, when the heart is pumping, that's when all the blood vessels get filled. Not the case with the coronary vessels. And that's just because of the way it's designed. Does that make sense? This video is in your module, but basically it's just showing you what it looks like when the coronary vessels are filling, and this is just a contrast dye that's being pumped into the vessels during an angiography procedure to see where blockages might be. I don't know, I think it looks really neat. This guy, he had, this is his stuff, and he posted it on YouTube just to share with everybody because he thought it was so cool, which I wish more people would do. So, if you want to see more of that, the video is freely available to you. All right, then we have the major vessels of the heart. All right, and you guys found all those yesterday. We've already talked a lot about the aorta, a lot about the pulmonary trunk, just with the fetal circulation and the valves. But we also have blood coming into the heart. All right, so into the right side of the heart, into the right atrium, we have left atrium, the pulmonary veins. All right, pulmonary veins coming back from the lungs go into the left atrium. And then the superior and inferior vena cava enter into the right atrium. All right, we're going to go over the path of blood flow through the heart at some point today. If you don't already know it, pick it up then. If you know the pathway of blood through the heart, that will allow you to go through every single structure of the heart as you're moving along. So I think that's a really good exercise to get into the habit of. All right, now let's get to some physiology. Which I need. I don't think physiology is neat. Cardiac muscle. All right, this is a cartoon of cardiac muscle. Looks very similar to what other kind of muscle? Skeletal. Why? Because it has these striations, actin, myosin, interdigitating across one another. Difference is cardiac muscle, highly branched, one cell or one nucleus per cell, and you have these intercalated discs between each cell. And basically what those intercalated discs are actually, does anybody know what they are? Or do you remember?
Sort of like gap junctions.
They are gap junctions.
They conduct the electricity down the entire muscle.
Right. So they're gap junctions that allow one cell to communicate with the neighboring cell by transporting calcium specifically across them. All right, so the intercalated discs are just high concentrations of gap junctions. You guys will see me if a marker stops working. I'll just throw it across the room and move on to the next one. That allow all these cells to have almost a continuous electrical signal that allows the heart to contract as a single unit rather than individual cells. All right, so when talking about these cells, we have to talk about how they are triggered to contract. All right, so we'll get into that a little bit and then move on to the conduction system of the heart. Before we start, I always draw it like this because it's, I think of the nervous system when I think of potentials, so I always draw an axon. What do we know about an axon in terms of charge? What is the outside relative to the inside? Outside is positive. Inside is negative, right? And usually you guys are used to this, seeing the probe inside that's measuring the potential. So outside is positive, inside is negative. This is important to understand what we're going to be talking about. What ion is predominantly on the outside? Sodium. Anybody know what the raw concentration is? No? Didn't you have labs this week? Like with Professor Cruz? Didn't she talk about, you didn't talk about that yet, did you? About 135 to 145. That's usually the blood concentration, since that's continuous to tissues. What's on the inside? Potassium. Anybody know what that is approximately? 150. All right. So that doesn't explain the positive and negative. The negative on the inside is usually due to a lot of negatively charged proteins that don't move, so they keep the inside relatively negative. All right. Why do we mention sodium and potassium? Because those are the ions that are going to change the potential of the cell. All right. The other one we want to consider is calcium. All right. And calcium is always on the outside, or in higher concentration on the outside. So if you have ions that are in high concentration on the outside, if I open up a channel for them, what are they going to do? They're going to go inside, right? And so if I open up a channel for potassium, it's going to go outside, all right? That's your brief primer in electrophysiology. So when we talk about ventricular muscle action potentials, the things that we're discussing, this is what's happening, okay? So starting at about minus 80, that's the resting potential of our muscle. In order to start a contraction, we have different phases. All right, phase 0, 1, 2, 3, and 4. Phase 0 you have this sharp spike going upwards. That means a whole lot of sodium channels are opening up, right? So fast sodium channels open up, right? Then towards the end, slow calcium channels are going to start opening up, right? And that's going to be important for a particular reason we'll discuss in phase 2. All right, so that's going to take the potential from negative all the way to positive, like instantaneously. You notice there's no time course here, straight up. All right, at the top, phase 1, potassium channels open. All right, so this is sodium rushing into the cell, calcium starts rushing into the cell. You get more positive, more positive, more positive. Potassium channels up, potassium starts going back in. Well, you're not going to get as positive anymore, right? You're going to start going in a negative direction. But what do you think, it's not listed here, but what also has to happen in order for that potential to start going down? You don't just have to open potassium channels, you have to close sodium channels. So sodium channels will also close right around phase 1. All right? So you notice the potential start going downwards, all right? You still have slow calcium channels open, but the potassium channels, throwing potassium out, are going to start bringing the potential down, all right? Phase 2, you have more calcium channels opening. So now you're starting to say, all right, potassium, I've had enough of you for now. We're going to even out. We're going to even out. So more calcium channels open to keep that at like a plateau, all right? That plateau is important. About what number is the plateau? What did you say? Did you say something?
I was just talking to myself. I said 2.
2. Oh, no. Like, potential. It's about 10 to 20, right?
Oh.
Positive direction. Sorry, I didn't mean to. So you plateau. The reason why you plateau is if you're in a positive potential, you can't open up more sodium channels. Therefore, you can't send another action potential to stimulate contraction. We call that a refractory period. All right, so it prevents the opening of sodium channels to get another action potential started because you want them to happen in a very sequenced way. All right, so then 3, you're coming back down. Anytime you have a straight down, that means potassium channels are opening up in wide mass, allowing potassium to flow out until you get back to resting membrane potential. Potassium channels close and nothing's moving. Make sense? Okay, it's just movement of ions. Quick reference. When we're talking about this, what is the one protein, big protein, that maintains resting potentials in all membranes? It keeps sodium on one side, potassium on the other. Sodium potassium pump. So that's also in here somewhere, maintaining resting potentials. All right? So that's how the ventricular muscle action potential works. But in order for that ventricular muscle to contract, we have to stimulate it to contract. All right? Notice, that they're in normal electrophysiology, you have resting potential, and then you have like this graded potential until you get to a threshold, and then you get an action potential, right? But you don't see any gradation here. The reason why you don't see any gradation is because the muscle is dependent on your cardiac conduction system to stimulate it to contract. Opens those channels and boom, right away you got the action potential. All right, all of that starts at the sinoatrial node, or SA node, which is something you cannot see. Like, you can do all the dissecting you want. You're not going to be able to physically see this in the heart. But it's located between the right atrium and the superior vena cava. I'm out of shape or something. I found out I had a meniscus tear in my knee, so I can't run anymore, and it's killing me. I mean, I'm lifting, but I'm not doing the cardiovascular, so I'm getting out of shape and fat.
Can you like cycle?
I can. I need a bike though, or at least a bike that works right. And the time to do it. Sinoatrial node fires at about 70 to 80 action potentials per second. All right, so what that means is your heartbeat would be 70 to 80 beats per minute. I mean, 70 to 80 action potentials per minute. That would equal to 70 to 80 beats per minute. All right, that's where it's located. It's known as the pacemaker of the heart, and it spontaneously fires. Okay, so you don't need the nervous system to stimulate it. It will spontaneously fire, and we'll talk about how that happens in a minute. So it will spontaneously fire. And then it conducts signals across the atria. So you notice there are fibers going across the atria. So when that fires, it's going to stimulate the atria to depolarize and eventually contract. All right, so from the SA node, you got to spread out to the atria. Okay. So, how does that work? Like on that more action. All right. Negative. All right, resting, right? Negative is always resting. Depolarization is going to a positive potential. So, where do I want to start? Here. Here's our resting. Here's our resting potential down here. We have a spontaneous increase in potential going in a positive direction. The reason for this is there are leaky sodium channels. So sodium channels are kind of leaking sodium out of the cell or into the cell? Into, right? Sodium's always high on the outside, so they're going to leak into the cell. So that's going to drive the potential up relatively slowly. I mean, it's fast, it's less than a second, but relatively slowly until you get to a threshold. You know, I don't care that you know what the thresholds are, but you're going to get threshold, and then you're going to spike in action potential. All right, and the action potential is the result of sodium as well as slow potassium or calcium channels opening. All right, so that's going to trigger that action potential. Okay, then potassium channels are going to open and bring it back down. All right, then potassium channels close, leaky sodium channels bring it to threshold, sodium and calcium bring it up, plateaus, potassium channels open, brings it back down. All right, the important thing here is this part right here. This is happening because sodium's leaking in. And because sodium's leaking in, that's going to spontaneously trigger that action potential without the need for the central nervous system to trigger it. Does that make sense? All right. So that's going to occur in a rhythmic fashion. So the sodium channels are going to leak at a certain rate, and that rate is 70 to 80 per minute. All right, once we've spread that action potential across the atria, we also have fibers that are going down to the next node, which is called the Atrioventricular Node. And the name of it tells you exactly where it's located, between the right atrium and the right ventricle. All right, so all of this is like on the right side of the heart, but it spreads to the left. Excuse me. If you didn't have any of this, if you didn't have the SA node connected to the AV node would fire at about 40 to 60 beats per minute. So when you have like heart blocks, like the SA node's not working, beat would be about 40 to 60 beats per minute. So that's what that information up there means. All right. The purpose of the AV node is, one, to transmit the signal from the SA node into the ventricles, but also to slow down the impulse to get to the ventricles. Now, why would you want to slow down the impulse between the atria and the ventricles. Pardon?
Fibrillate otherwise.
I still didn't hear you.
Fibrillate otherwise and just be chaotic.
Yeah, you'd have atria and ventricles contracting at the same time, essentially. All right, which would lead to a fibrillation. All right, so that's got to slow down. All right, and then you have this AV bundle, which is taking those that signal down to the septum of the heart. The septum means wall, so the wall between the left and right ventricles. That's called the AV bundle. All right, and that's going to divide that. If you have the SA node blocked and the AV node blocked, this would fire potentials at 30 to 40 per minute. And then that's going to break off into left and right bundle branches. This is going to stimulate the right side of the heart. This is going to stimulate the left side of the heart. Both of those, if everything above it's blocked, fire at 20 to 30 per minute. All right, then you're going to go down to the apex of the heart, and then you're going to have these Purkinje fibers spreading upward. All right, they start here, then spread upwards towards the base of the heart. Those Purkinje fibers fire at 15 to 20 per minute. Everything above them is blocked. Okay?
Differential to what they would go at if it was a block above them.
Yes. Yeah, you do, because when you get to ECG, this is going to come up, and that's next semester. Speaking of ECG, all right, all the electrical activity in the heart can be measured through an ECG, formerly known as Ecg. People still use that though, Electrocardiogram. All right, it's just a map of the electrical activity of the heart. Okay, this is what one beat would look like. This is what the second beat would look like. And so you have to know what these waveforms mean. All right, we're not going to get into a whole lot of detail in interpreting ECGs. That's for your clinical classes. But you do have to know P, the Qrs complex, and then the T wave. P wave, Qrs complex, T wave. Can somebody look ahead? Do I explain these in the next few slides? Nope. So I'll explain that. Thank you. So P wave. Does anybody know what that represents? No? Thank you. Atrial depolarization. All right, so the atria electrically are becoming more positive. That's the electrical stimulation. Qrs complex would be ventricular depolarization. And then the T wave would be, right, ventricular repolarization. Somebody's excited about EKG class. So you get to pay attention. You get to know who to come to. That's the last thing. Pointing her out right now. Lindsay. Right?
What?
Lindsay. Okay.
Oh, I thought you were just saying her name just to say it again.
No, I'm still trying. I've got almost everybody's name, but I'm checking myself. Don't ask me. Don't like.
That's why.
You don't want to go around.
Snoop Dogg. All right. So we have atria depolarizing, ventricles depolarizing, ventricles repolarizing. What am I missing? Atrial repolarization. Why am I missing that? Right. The electrical signal from the ventricles is so strong that the P wave repolarization is masked, so you're never going to see it. I'm sure there's some kind of maneuver or thing you can do to look at it, but it's really not that important. I don't think any anything clinically significant goes wrong with it. So this is what you're looking at. This would be what a normal ECG strip looks like. So it's divided into 0.2 second intervals, and each 0.2 second interval is divided into 1, 2, 3, 4, 5 boxes, right? So that means each box would be 0.04 seconds, right? 0.04 times 5 boxes is 0.2. All right, so when you get to your EKG, you're going to be taking EKG calipers and like measuring this and recording what we call PR interval, QRS, PR interval, RR interval, things like that. So you can determine, there are certain time courses that these are supposed to occur in, and if they occur longer than that or shorter than that, you have some electrical conduction problems. But I want you to be aware of what it is, what it looks like, and what they mean, because we're going to talk about how that relates to contraction. Later. Okay. My watch told me I needed to record. I'm like, is my phone stopped recording? It hasn't. All right, so this is what it looks like in terms of what's happening. So the development of your ECG. The yellow represents the depolarization. So you start the depolarization in the right atrium, because that's where the SA node is. It spreads, so by the time you get the atria totally yellow, you've had your P wave, right? Why do we have a P wave? Why do we have atrial depolarization? What happens immediately after that? Pardon?
They fill with blood.
No. They contract. You have the electrical signal, then you have the mechanical signal, right? You have the electrical occurrence, then you have the mechanical event. So you have to have the electrical stimulation to trigger a mechanical contraction. All right? So as soon as the atria start repolarizing, so that's what that green means, the ventricles start depolarizing. And notice that the ventricles are depolarizing in an upward fashion. Right? So if the ventricles are depolarizing in an upward fashion, that means the contraction is going to happen in an upward fashion. Why? Because your vessels are at the top, right, at the base. You want to squeeze upward. So you want to start contracting down here and squeeze up this way. So that's why it's stimulated to contract in that way. So by the time they're fully depolarized, that's your Qrs complex. As soon as they're fully depolarized, they start repolarizing in the same direction, and then you have your T wave, and there's your full EKG tracing. Okay? One thing why I have this right here, I remember we're squeezing from the top to the bottom, but our cardiac myocytes, our muscle fibers, are aligned in a swirling pattern. So not only are you squeezing upward, but you're twisting as well. Kind of like those mops, you twist them and squeeze them to wring them out. Your heart does the same thing. So it squeezes from the bottom and twists, so you get every last bit of blood that you possibly can out of it. If you didn't have that twist, you may get half the blood out. Does that make sense? I don't like these red scripts because they don't fit right. But I'm Team Red today. Go Team Red. Who's Team Red? All right. And then you have this pattern right here. All right. So that's what an ECG tracing. Yes. Let's show the video so I can show them.
The Electrocardiogram, or ECG, is a recording of the heart's electrical activity. Placed at standardized points. Examination shows how the different ECG waves are produced during the cardiac cycle. The P wave corresponds to atrial depolarization. The impulse then travels through the Atrioventricular Node, producing a flat section on the ECG, known as the PR segment. The PR segment is flat because no current is flowing through the cardiac muscle cells. As the impulse travels from the AV node to the bundle of hits and along the upper part of the septum, the Q wave is produced. The passage of the electrical signal through the ventricles produces a large spike called the Qrs complex. The Qrs complex is much larger than the P wave because the ventricles are much larger than the atria and so produce more electrical activity. Most of the Qrs complex represents depolarization of the left ventricle, which has much greater mass than the right. The impulse remains unchanged for a moment as the ventricles remain depolarized. This gives rise to another flat section, called the ST segment. As the impulse fades away and the ventricles repolarize, the T wave is formed. Note, this animation shows the ECG recorded from a lead placed at position V6, one of the standard electrode positions to the left of the heart. Leads at other positions detect the electrical activity of the heart from a different point of view, and therefore produce differently shaped ECGs. As you will see, during atrial fibrillation, the electrical activity of the atria becomes disorganized. As a result, there is no P wave on the ECG for patients in atrial fibrillation. The absence of P waves is one of the most important features used to diagnose atrial fibrillation.
All right, with that, I'll take 5. High ovary. All right, start recording again. All right, so we've been through the heart, we've been through the electrical activity of the heart, and now we're going to start getting into the mechanical events of the heart, so the contracting and how that cycle occurs. I did bring these for a reason. So we'll start by finishing up how the regulation of this electrical activity occurs at the level of the central nervous system. So we know that the SA node controls heart rate. And what was that normal heart rate of the SA node? 70 to 80, right? But there are conditions in where we may want to change our heart rate. What are some of those conditions? Fight or flight, trauma, rest and digest. Okay, so fight or flight, rest and digest, I guess covers everything. Thanks. Killjoy. I was like, exercise, or like constantly shopping. No. Fight or flight. All right, so we have 2 inputs from the central nervous system, and that is from the vagus nerve, the parasympathetic nerve fibers. So the vagus is parasympathetic. Parasympathetic is rest and digest. All right, so rest and digest, and that means that's going to slow down our heart rate. So parasympathetic fibers through the vagus nerve slow down our heart rate. It works through acetylcholine, and what acetylcholine does is it opens up potassium channels. Potassium channels makes our potential more positive or more negative. Actually, when potassium is flowing, it makes our potential more positive or more negative? More negative. So you remember this green chart right here that represents our SA node. Back up. Parasympathetic and sympathetic fibers go to the SA and AD nodes specifically. They don't just go anywhere in the heart. They go to the SA and AD nodes. As these parasympathetic fibers open up potassium channels, that makes the resting potential more negative. If you're more negative, it takes longer to reach threshold. And if it takes longer to reach threshold, what's that going to do to the amount of beats per minute? It's going to decrease them. That slows down your heart rate. So that's one of the reasons why we painstakingly went through, the SA node action potentials, because when you put the brakes on, you make it more negative, which means it takes longer to reach that threshold potential. Therefore, you slow it down. We also have accelerator nerves through the sympathetic nervous system. So what these do through norepinephrine is they increase heart rate by opening up sodium and calcium channels. All right? If you open up sodium and calcium channels, you don't get as low of a resting membrane potential. So you end up being closer to threshold, and therefore it takes less time to get to threshold. If it takes less time to get to threshold, you have less beats per minute. Less intervals, shorter time between beats, therefore more beats per minute. Okay, so through opening up potassium channels, making things more negative, opening up sodium channels, making things more positive, we regulate the resting membrane potential to make things faster or slower in the SA node. All right. As a side note, the sympathetic nervous system also increases the strength of contraction because it goes directly to the muscle fibers and causes them to contract more vigorously. Right? So sympathetic not only increases heart rate, but it also increases strength of contraction. All right. Within the medulla oblongata, which is in the brainstem, we have two centers, reflex centers, for regulating heart rate. We have the cardioinhibitory reflex center, which would act through sympathetic or parasympathetic. Cardioinhibitory. Parasympathetic. And the cardioacceleratory reflex center, which would be sympathetic. Good. All right, so we also have baroreceptors that respond to changes in blood pressure. So remember, where did I say the baroreceptors were located when we were talking about respiratory stuff on Wednesday? Carotid arteries and aortic arch. All right. So baroreceptors are also going to be located there. They're going to detect pressure changes. Remember, this is all a circuit. Like you have the sensors, you have the regulators, and then you have the effectors. So if the aortic arch detects low blood pressure, it's going to send a signal up here to the medulla oblongata. It's going to activate what? Which of those two centers? Acceleratory or inhibitory? Acceleratory. The acceleratory is going to send sympathetic signals to the heart, to the SA node, and say, hey, blood pressure's low. We're going to want to do what? Increase heart rate, right? What's that going to do to blood pressure? Bring it up. All right. Likewise, if the aortic arch or the carotids detect increases in blood pressure, that's going to send a signal to the medulla, specifically to the cardioinhibitory center. That's going to tell the vagus nerve to say, hey, blood pressure is a little too high. Let's lower the heart rate so that we can bring it back down to within normal parameters. So these baroreceptors help to modulate heart rate and therefore modulate blood pressure as a result. We're not going to get into blood pressure today, but I do want you to be familiar with these equations. Blood pressure is a function of cardiac output times peripheral resistance, right? So things dealing with the heart and things dealing with the blood vessels. And we see that here. Changes in blood vessels are going to affect what happens in the heart. Cardiac output, then, is a function of what? Anybody know? Heart rate? Stroke volume. Good. It's a function of heart rate and stroke volume. These will come back when we get to the blood vessels. So we're only covering heart today. Like in I think 2 or 3 weeks, we'll cover the circulatory system. So that there shows you that whatever happens to blood pressure, you're considering what's going on in the blood vessels as well as the heart. The reason why I show those now. All right, blood flow through the heart. Remember I said that's an activity you guys want to get familiar with. We've already gone, I think, did we go through? We'll go through it. Systemic circulation. I always start at systemic circulation. Most books always start at systemic circulation just because it's easy. Systemic circulation, you're draining blood back into what? What are these vessels? Vena cava. Into the right atrium, through the tricuspid, into the right ventricle, through the pulmonary valve, into the pulmonary trunk, pulmonary arteries, lungs, back into the pulmonary veins, left atrium, bicuspid, left ventricle, aortic valve, and aorta, back out to systemic circulation. Yay! Does anybody remember those Eddie Murphy, the nutty professor?
Oh,
and there's a scene in there where he goes,
Professor
Hercules, Hercules. Nobody remembers that anymore. So, if you can't do that and you want reminders, no, not that. All right. So years ago, they made this aspirin commercial that actually, this guy sings a song about the flow of blood through the heart in relation to St. Joseph's aspirin, because you should take one a day to prevent blood flow problems. So. All right, so I missed a couple valves there, but it still went through the heart. So if I like pictures like this because this is how I think. I like to see the map. I put a flow diagram over here just in case anybody likes flow diagrams too. Like some people like flow diagrams better. And for certain things they work. So whatever, I'm never going to ask you a simple question like blood flow through the heart. It's always going to be like in relation to something else. Okay? Because when we went through there, everybody was like answering in unison. Except for that one time when I heard tricuspid, 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 tricuspid. So I got a feeling you guys know that. Back up. How much of what we covered today is complete review? Most of it? Okay. But
We can still test this on
I know,
if you
yeah.
And we can also keep
the more you hear it, the more it sinks in, right? Okay. Has anybody seen this diagram before? No? Some people? Yes? Okay. This shows the entire cardiac cycle and all the events of the cardiac cycle where they occur in relation to each other. Okay? So to point out, here's your electrocardiogram, right? So you see the P wave, Qrs complex, T wave, P, Qrs, T. All right, those are the electrical events. Up here, you see the red line, ventricular pressure. What causes ventricular pressure? Two things. One, heart contraction, and two, filling blood. Okay, so here's the ventricular pressure. These dotted lines represent aortic pressure and atrial pressure. Okay, so just to show you where things are, this blue line represents ventricular volume. Okay, ventricular volume. So what's happening in the ventricles as they fill and empty. And then down here we have our phonocardiogram, which is our heart sounds. S1, S2, right? So, we're going to go through this step by step. You're going to see this slide over and over again, but with different parts highlighted to show what we want to show. So this is just a general overview of what it looks like. If you want to come back to it without all of the other stuff on it, this will be the slide to come back to. All right, so with the cardiac cycle, we have two parts. We have systole. Systole equals what? Contraction. All right, systole is our contraction. Diastole would be our relaxation. Diastole would be relaxation. Okay? And we talked about the EKG. So nothing on here is new instead of introducing systole and diastole, which you guys already know what it is. All right. Pointing out the atrial pressure wave, there are three components to it. Your A wave, your C wave, and your V wave. All right, atrial pressure. So those are the chambers above the ventricles and what is causing them to have higher pressure versus lower pressure. So the A wave is our atrial contraction. All right, that should be the highest point of pressure because you're literally contracting them and pushing blood out. So that A wave represents atrial contraction, and that can be seen as a pulse in our right. That's the right internal jugular vein. Okay. When you guys do physical exam, no, you can't feel it. I thought that was my carotid, but you're telling me. No. When you guys do physical exam, I don't know if did Professor Gavin talk about the jugular?
Not in every group. He's been teaching us different things. Yeah.
I've seen enough of what he's doing that I know what to test on if I'm going to test on it. So he doesn't take part in any of the development of testing. I do. So it's based on what I see. Good to know, though. Thank you.
Yeah.
So you can see that if you lay your patient or you guys at 45 degrees, turn your head, you'll be able to see pulses in the jugular vein related to contraction of the right atrium. So what you're doing when you're measuring that is measuring the actual function of the atrium indirectly, right? Because it's going to push blood back up this way as it's contracting simply because veins are low pressure units. All right, C wave, ventricular contraction. Okay, so ventricular contraction. Atria contract, they come down, ventricles contract, that builds up pressure, that's going to push blood back up a little bit. You can see a second pulse, so what you'll see with the jugular vein is two pulses in succession, and that's going to be your A and your C. And then the V wave would represent flow of blood into the atria. As the atria are filling with blood and the AV valves are closed, it's going to fill up and cause another pressure wave, increase in pressure as it's filling. All right, so that's what you're looking at when you do that. For the sake of time, I'm going to skip the video, but there's a video on this. You can get to it through the PowerPoint, or you can get to it through Canvas as well. I put the link. I embedded it in your Canvas module. All right, so that's the atrial, and that's all we'll mention about that. All right, going to what this really means. Systole. All right, you told me that's contraction. So what happens during contraction? All right, first of all, what's this right here? P wave, atrial depolarization. All right, notice that the P wave ends before the atria start to contract, right? This is a pressure buildup in the atria that occurs after the P wave. It's important to understand this. All right, all your mechanical events happen just after our electrical events. All right, then we have the atria contract. All right, when the atria contract, after they contract, so back up. Systole means contraction, diastole means relaxation. When we talk about systole and diastole, however, we're usually talking about ventricular systole and ventricular diastole. Why? Because that's the business end. We're pumping out to the body or the lungs. We don't care about pumping into the ventricles because the ventricles don't really require pumping to fill up. Okay, so now we're moving into ventricular systole. The AV valves are closed. We filled up the ventricles. All right? So the AV valves are closed and we're starting to contract systole. So here's our QRS complex. Notice that the QRS complex is mostly done by the time pressure starts building, which is an indicator that the ventricles are contracting. Since the semilunar valves are also closed, or the aortic valve is also closed, pressure is going to build up, but no blood's going to go anywhere. We call that isovolumetric contraction, or isovolumetric. You'll see both terms. All right. Up until the pressure in the ventricles is greater than the pressure in the aorta. All right, because remember, what's keeping the aortic valve closed? The blood. Blood is sitting there, right? And it's keeping that valve closed. So when we start contracting the ventricles and the pressure in the ventricles overcomes that pressure that's in the atria, you're going to push that valve open and blood's going to start flowing out. Pressure's still going to be building up, but what do you see happening to the volume of the ventricles? It's decreasing. That means you're pushing blood out. Okay? Then there's a point where the pressure of the aorta is greater than the pressure of the ventricles, and the aortic valve is going to snap back shut. I forgot to mention something, and I completely fucked that up. Back here. When the atria contract, and then the ventricles start to contract and close the AV valves, that's when we hear our first heart sound. I forgot to mention that. So notice that the AV valve's closed, and that's when we hear our first sound, S1. Okay, so what made me remember that is that when we close the aortic valve, when the pressure in the aorta is greater than that in the ventricle, and that aortic valve snaps shut, that's when we hear our second heart sound, S2. Is it just the aortic valve that's closing? No. What else is closing? Pulmonary. He's like semilunar. I saw the yes, so I performed. Huh?
So you got to call me out, huh?
No, I'm not calling you out. You were right, though. It is a semilunar valve. Yeah, you guys are both like All right, so aortic valve is going to close. All right. You have this. We'll get to that. Actually, no. You have this little bump here called an incisura, and what that means is that notice that the aortic pressure is decreasing, but then it increases rapidly because those valves close, and there's temporarily a increase in blood in that area, and it's going to bulge out, increasing pressure. So that's what this little thing is right here. All right. So that is systole. Diastole occurs next. All right. So think about this. We have close the aortic valve. We know that the AV valve is also closed. So when the ventricles are relaxing, you have this period where no blood exchange is occurring in the ventricles. So that's called isovolumetric relaxation. Both valves are closed, so nothing is going in or out of the ventricle. All right. Once that period is over, AV valves are opening. Notice that blood starts filling back into the ventricles. All right. Why does blood fill back into the ventricles when? Never mind. We'll put it this way. The ventricles are filling up, not really the atria, because 75% of the ventricles are filled by the time the atria contract. So blood is pouring in, let's say, from the superior and inferior vena cava into the atria and right into the ventricle. The atria contract then to push the rest in. Does that make sense? So the last 25% is caused by the atria pushing into the ventricles, right? Which is mentioned here. And that's what's occurring here. So here's the atrial contraction, pushing the last of that blood in. That's this right here, the last of the blood being pushed in. Most of it occurs just by filling with the AV valves open, right? And then we start the cycle all over again. All right, why I brought this. When we talk about heart sounds, you guys learned yesterday, did he teach everybody S1, S2?
No.
No. Okay. S1 is your first heart sound. All right, S1 is your first heart sound. And based on what we just talked about, remember it's the AV valves closing. The AV valves, so between the atria and ventricles, it's those closing. It's the loudest sound, it's going to be low pitch. The second heart sound is the semilunar valves closing. Okay, so second heart sound, so when you hear looked up, looked up, looked up, love is your S1, duck is your S2. Okay, you also have a third heart sound. Most people don't hear it. I can't hear it. I haven't officially heard it yet myself. But it's very low pitch, and it's basically blood rushing into the ventricles. So it's not going to sound like a doop. It's going to be like, okay, third heart sound. And then there's a fourth heart sound that is generally abnormal. So you're not going to hear it unless you're listening for abnormal sounds. Okay, unless the person is sick. All right. When I have my stethoscope on and I'm listening to heart sounds, and I'm right here, what am I listening to? Aortic. All right. Based on what we see here, if I'm listening to the aortic valves, because that's what aortic means, right? It's an aortic valves. Which sound is going to be louder, S1 or S2? S2. So it's going to be lugged up, lugged up, lugged up. What's this heart sound? Pulmonary. Is that still one of your semilunar valves?
Yes.
So which sound is going to be louder? S2 still. Lugged up, lugged up, lugged up. I move down. So second, third intercostal space. What's that? Herbs, also known as second pulmonic. So I'm still listening to my semilunar valves. Which heart sound is going to be loudest? Still S2. Lugged up. Or no, S2. Lugged up. Lugged up. Was I saying that wrong the whole time?
Yeah.
You guys, no wonder why I was getting looks from you.
Yeah.
I was just waiting for like the operation after.
I was having confused on my face.
No, I'm sorry. Looked up, looked up, looked up. All right. Then we move down to the fourth intercostal space. What's that? Tricuspid. Now we're listening to the AV valves, right? Now you're going to hear the lugged up, lugged up. First sounds louder. And then fifth intercostal space, midclavicular line, mitral. First sound's going to be loudest. Lugged up, okay? Now, when you were listening to the aortic and pulmonic areas, aortic valves generally close before the pulmonary valves. So you might hear within your second heart sound, which is going to be the louder one if you're listening here and here, right? Two distinct sounds. That's what we call splitting. All right, so you might hear the aortic valve close before the pulmonary valve. It takes training to hear that. So if you don't hear it right away when you get to your physical exam lab or when you're sitting here, right, nobody's home. Yeah. It'll take a while. Okay, but eventually, is anybody in here interested in cardiology? Surprise. Cool. So, actually, if you guys are interested in cardiology, one of our 23 cohort, Andy, I don't know if you guys know him.
He's my mentor.
Is he? He's also interested in cardiology, so you may want to talk to him and strike up that conversation. Okay. You've seen this before. I'm only adding two things. Here, when your ventricles are relaxed, should they be full or should they be empty? More full or more empty? More full, right? So we call that end diastolic volume, and that's going to be a higher number. When our ventricles are contracted, they should be less full. We call that end systolic volume. So our end systolic volume and our end diastolic volume. All right. After contraction, after relaxation. All right. Why I mention those is if we take our end diastolic volume, which is about 120 milliliters, and subtract our end systolic volume, which is about 50 milliliters, we get our stroke volume. So end diastolic volume minus end systolic volume is our stroke volume. Stroke volume, by definition, then, is how much blood, what's pumped out of the heart, right? So that tells you that you always have an amount of blood in your heart, right? It's never completely empty. So 120 versus 50. So that's your stroke volume, 70 milliliters. We usually measure cardiac function by the ejection fraction. What percentage of blood was actually pumped out? All right, so that's our stroke volume, 70, divided by our end diastolic volume, 120. So 58% of our blood was ejected. Normal is 60%. All right, so under normal conditions, about 60%, just over half of your blood is ejected. All right, that's normal. So when you calculate stroke volumes and you know end diastolic volumes and you see ejection fractions of 30%, that tells you you're not pumping efficiently. Okay, if you see ejection fractions of 80%, that means you're probably exercising or in a stressful situation or things like that. Okay, so extending from that, if your heart rate is 70 beats per minute, what's normal heart rate? 60 to 100 is pretty typical. 70 beats per minute, what is the cardiac output? We talked about cardiac output over there. So cardiac output, heart rate times stroke volume, 70 times 70, 4,900 milliliters per minute. So if you have a stroke volume of 70 and you're operating at 70 beats per minute you're pumping about 5 liters of blood. How did I get 5 liters? Move the decimal point. See, I'm used to working with undergrads, and you're like, you didn't tell me this was going to be math in here. We've already talked about all of these. We talked about the aortic pressure curve, why this occurs. So I'm not going to go into this slide in any more detail. We talked about it. I don't know why all of a sudden I'm having all of this stuff going on. Yes. I used to use that stuff all the time, and I'm like, it takes so long to put these in. I'm like, fuck this. All right, so valvular function. Why do we have valves? The whole purpose of valves is to do what? Prevent backflow of blood. You want it flowing in one direction, not the backflow direction. When blood does flow backwards, what do we call that when we're listening? Murmurs. Okay? So we talked about this. The only other new thing, because of smaller openings, velocity through aortic pulmonary valves, because you're pumping from the ventricles as opposed to pumping with gravity from the atria. The velocity of blood is faster going into your blood vessels than it is going from atria to the ventricles. I mean, that's given. Jesus. I didn't put those in there. All right. We can look at the work of the heart by looking at pressure volume curves. So you guys looked at these before? Maybe pressure volume curves or loops? Pressure volume loops? No? Okay. So we're going to interpret those in a minute. Work output, work of the heart, is affected by two things. These are two concepts that are going to be really important to know, especially if you're going into cardiology. Preload and afterload. All right, preload is always going to be your volume load. Your volume load. How much volume is coming back to the heart? All right, and that makes sense because our measure of preload is our end diastolic pressure when the heart is what? Full. All right, so preload is how much blood is coming in. How much do you have to pump out? All right, afterload is the load that you're pumping against. All right, and your heart is pumping, remember we're talking about ventricles, your heart is pumping against resistance, like these small vessels relative to the size of the heart. So you're pumping against a pressure load. So afterload is a pressure load, specifically in the aorta. Okay, so preload is volume, afterload is pressure. All right, now we know that we pump about 70 milliliters of blood per beat, 70 beats per minute. Can we pump? Does our heart go faster? Yes. Does our heart pump more than 70 milliliters? Yes. Per beat? Yes. So what that tells you that so you know then that the heart's capable of pumping any excess blood that comes in. You get excess blood coming in. When would you have excess blood coming into your heart? Exercise. Or walking around. As soon as I start walking around versus standing, my veins are pumping blood right back to my heart. And automatically my heart's going to stretch and start pumping faster and harder. So even walking from here to there, I had a transient increase in heart rate. Right? Transient increase in contractility. Within physiological limits. So like you're not going to say, all right, we're going to pump 5,000 liters or 5,000 milliliters, 5 liters right away. It's going to be within physiological limits. Otherwise, what's going to happen with the heart? Speaking of dead space. Without excessive backflow, so you don't overload. So our heart is capable of doing this through something we call the Frank-Starling mechanism. What the Frank-Starling mechanism says is that the farther the heart stretches because of an increase in blood volume, the harder it's going to contract. That's all it says. You can look at all the fancy equations and all the fancy terminology they use, but really, more blood volume, larger stretching, harder contraction. That's what the Frank-Starling mechanism is. Which is then going to increase your ejection fraction. And we talked about some of those things. So this is a pressure volume diagram. All right? And what it's showing you is basically all of the phases of the heart that we talked about in that other diagram, but in a circular format. So we will start here. Here's your period of filling. What's filling? Actually, back up. So here's our volume. X-axis is our left ventricular volume. Right axis is our left ventricular pressure, so the pressure in the ventricle. All right, so here we see volume increasing, pressure is increasing slightly, right? So here would be our end diastolic volume. We're relaxed, we're filling up our maximum volume. Then we start to contract. All right, volume's not changing, so that's our isovolumetric contraction that we talked about in that previous slide. So this is just another way of looking at that same picture that we saw earlier. All right, here our aortic valve opens. And when our aortic valve opens, now we start to see volume decreasing, right? Why? Because if the aortic valve is open, we're pumping blood out into the aorta. So our volume in the ventricle is going to decrease. And at the end of that, that's going to be our end systolic volume. Okay? And then we enter a period of isovolumetric relaxation where no volume change is going to occur. You're going to relax and then start filling again. So this loop will go over and over and over again. Well, this is one of the, I've done this in rats. So we anesthetize rats. We open them up. We stick a catheter in their carotid artery down into their heart, and we get these pressure volume loops. And then we give them drugs to increase heart rate and stress them out, called dobutamine, and then measure how they respond. Okay, so I've actually done these before. It's a pain in the butt. And I cut through a $5,000 catheter. Okay, this is showing the same thing. All right, the other one was I didn't make it. I borrowed it from your text. This is another of the same thing, so the work output. So that's basically what we're describing as the work of the heart. So whichever one you like better, use. External work. All right, why do we want to talk about this? To see what happens when we increase different load, like preload or afterload of the heart. So what happens if we increase preload and get an increased stroke volume? Okay, so we have our period of filling, but we fill above and beyond, right? So our end diastolic volume is going to be higher, right? When we the work of the heart is the area under the curve. So the filling of that box is what the work is. Okay, so if I extend the box, what's going to happen to the work? It's going to increase, right? Basically, that's what this is showing. All right, do I need to go through all of this part here? No, do I? Please. All right. So, increased volume results in increased work. It's going to take more pressure. Notice the pressure's higher to push that volume out. Therefore, the work's going to be higher. If I have an increased afterload. Afterload is what? Pressure or volume? Pressure. Okay. I fill. I pump. But because I have a higher pressure to pump against, it's going to take much more work for my heart to pump against that pressure. That's why my pressure is higher right here. All right? And then as I pump, because that pressure is higher, I'm not able to send out as much blood. Does that make sense? I can't send out as much blood, so my volume is going to be less. My total volume is going to be less. So you see a change in volume as a result of a change in pressure. Decreased volume pumping out because I have a higher pressure to pump against. So that increased afterload will result in a decreased stroke volume because I just don't have the muscle to pump against that higher stress. All right. Now let's say that I have a sympathetic nervous system innervating my muscle, and it's going to cause a stronger contraction. That's what we mean by increased contractility. I fill, I pump, but I'm pumping harder, so not only is my pressure going to be higher, but I'm pumping more blood out. therefore I have the capacity to fill more. And then that's going to continue. Okay? So an increased contractility would equal an increased stroke volume. So basically, the words at the top are what you need to know. Pictures are just proof that it's happening. All right, so autonomic effects on the heart. Sympathetic versus parasympathetic. Sympathetic stimulation, remember, increases heart rate because it's innervating the what? I didn't hear you. Yeah, the SA node, right, the SA and AV node. So causes an increase in heart rate, increased contractility because it's innervating the muscle. So heart rates can reach up to 180 to 200 beats per minute. Does anybody know what your maximum heart rate is supposed to be? Does anybody know the calculation for that? 220 minus your age would be your maximum. If you want to operate at 60% of your heart rate, 220 minus your age times 0.6. That's what that's. So 220 minus your age should be your maximum heart rate. I am 45. 220 minus 40 is 180. Minus 5 is 175. My maximum heart rate should be 175. So if I'm operating above that, that's bad, right? Mm-hmm. That means I'm doing things to my heart that shouldn't really be being done. All right, so that's how you calculate your maximum heart rate. And they say, like, if you want to be in a fat burning zone, X% of your heart rate, 220 minus age times 0.6 or something like that. If you want to operate in cardiac zone, 80% of your maximum heart rate, 220 minus your age times 0.8. So that's how you figure that out. All right, parasympathetic stimulation decreases our heart rate, right? We know that. And also decreases contractility slightly. Things to know here, sympathetic nervous system goes to the cardiac muscle, ventricular muscle. Parasympathetic does not. So the parasympathetic doesn't have as much of an effect on decreasing contractility or strength of contractions because the parasympathetic fibers don't go to the ventricles. They go to the atria, which has very little effect on your actual contractility. All right, important thing to note, if you have tachycardia, very fast heart rate, you're contracting and relaxing, but you're contracting and relaxing really fast. You don't get a full relaxation. If you don't get a full relaxation, does your heart fill as much? No. So that's going to decrease your overall cardiac output because your stroke volume is decreased. Okay? Increased heart rate, you're going to have an increased stroke volume if it gets to a certain point. All right, no time for the heart to fill. Okay, so this is just a graph showing what I was talking about. If we have SA node alone, this would be our cardiac output. If we have sympathetic activity, it would increase. Parasympathetic, it would decrease. So nothing really special for this graph. Just proof of what we talked about. Oops. Are we done, really? No? You guys are like, thank God. All right, so one more thing with contractility. Even though you guys said, like you guys asked me like hypocalcemia, hypercalcemia, hypokalemia, hyperkalemia, hyponatremia, hypernatremia, all those things that you guys probably forgot because it's boring and you don't want to think about it. I get it. It's important, especially for the heart. If you have excess potassium, blood, normal concentrations of potassium in your blood. Anybody know? About 3.5 to 5 milliequivalents per liter. If you have excess potassium, that actually decreases contractility. If you decrease contractility, you're not pumping as hard, right? So that excess potassium is going to slow down the amount of blood that you're pumping out. Okay. Too much excess potassium means you're in the death sentence chair. Anybody know how they kill people? Potassium chloride. Overload you with potassium and that shuts down your heart. Right? Excess calcium. God, I don't remember what the blood calcium concentrations are. I want to say 10 to 12, but don't write that down. You can look it up easily. Excess calcium causes spastic contractions. And low calcium causes cardiac dilation. So, sodium, the point here is electrolytes will affect your heart. Okay? Potassium is going to have the strongest effect. Too much potassium will decrease contraction. Too much potassium will also put you into an arrhythmia, a deadly arrhythmia. Too little potassium can also do that. All right. Calcium is the other thing that can cause problems. Excess calcium, spastic contraction. You don't want spastic contractions, right? It's not going to be efficient pumping blood. But you also don't want too low of calcium. That's going to affect the ability of your heart to contract as well. So if you have too low of calcium, you don't get strong contractions. That's what we mean by cardiac dilation. All right. So these two are going to be your primary electrolytes affecting the heart. So it's important to know what happens when they're high. It's important to know what happens when they're low. And that ends the heart.
Low K,